Welcome everybody. As you've all just being added, I'm just going to hand over to Gary Fettke, Dr. Gary Fettke, who's going to be our chair. We're lucky to have him step into the chair role today, which is wonderful.
Look, it's my great pleasure to introduce you to Associate Professor Dom D'Agostino. Dom and I have had a couple of conversations over the years. I've never actually met him face to face, apart from, I suppose, this. He is of incredibly good taste because he's married to a delightful lady. I know she's a delightful lady because my wife Belinda had a meal with them recently in San Diego. So I think Dom and I are both punching above our weights with Chilla and Belinda. Look, Dom, I would like to describe as one of the original gangsters in this keto low carb space, not from the last century, but in this modern era. And it's been my pleasure to observe his work and see his wonderful science being put forward. And he's being recognised more and more for that experience and that expertise. So he's currently a professor at the Department of Molecular Pharmacology and Physiology at the University of South Florida, senior research scientist at the Institute for Human and Machine Cognition. His research around therapeutic carbohydrate reduction, ketogenic diets, exogenous ketones, neurological disorders, cancer, human performance. His work with NASA, with the Navy SEALs, I think was the last time we had a conversation, Dom. Look, it's really, he's co-authored a book on the origin and future of the ketogenic diet. But Dom, you can't get it online anymore. I went to look at that. Really
Oh, really? I
supporting.
got to look into that. Yeah.
Yeah, look, it's supporting Tom Seafried's work, who is just a giant in this space. So it's just an absolute delight to welcome Dom to an Australian audience. I'll let him have the floor. But thank you, Dom, for making yourself available yesterday.
Yeah. Well, thank you for the invitation. I appreciate it. And I enjoy sharing this information with people. I've enjoyed my travels through Australia too, and just the remarkable country and people that seem to really have an appreciation for therapeutic carbohydrate restriction and ketogenic diets. So I am professor at the university, and I teach medical students, and I work and push as hard as I can to get this type of information into the curriculum. So this is a version of one of the classes that I teach, introductory class. So medical students, and I mentor many PhD students, master students, also teach in the honors undergrad program. So, and many of those students are like targeting med school. So I try to get them early so I can direct them down this path, and so they can implement metabolic therapy into their practice. So I do have a few disclosures in regards to research support, various patents, and we have a podcast, and we also host a conference, the Metabolic Health Summit, which we are gearing up to host again. So a little background on the talk that the information I'll be sharing today. We're going to maybe take a step back and just do like a ketogenic therapy kind of 101 and talk about ketones and brain energy metabolism and ketones as an alternative fuel, and kind of pivot into what we have termed ketone metabolic therapy. So that's an umbrella term that we use for therapeutic fasting, therapeutic carbohydrate restriction, calculated precision ketogenic diets that are weighed out with precision types of fatty acids that are like MCT oils and omega-3s. So we sort of engineer ketogenic diets, and working with the Moffitt Cancer Center, we personalize them to the patients too, to achieve certain biomarkers that I'll be talking about. And when I got into this field about just under 20 years ago, the only really legitimate accepted application for a ketogenic diet was pediatric epilepsy. And then a year after that, Johns Hopkins, Eric Kossoff and John Freeman did work to make it acceptable for adults to use the ketogenic diet as a dietary therapy for epilepsy, and typically drug-resistant epilepsy. And now there are many proven applications and many emerging applications, and I want to highlight just how the science has been evolving on that. And importantly, I think for the practitioners, what I get so many questions on is really the best strategies to achieve, to sustain therapeutic ketosis and to monitor ketosis. So this is also really important for the work that we do because we do basic science research in various animal models, but we do human clinical trials, and we need to sort of correlate the level of ketosis with the therapeutic outcomes. And that could be seizures, it could be cancer, it could be we're doing research with traumatic brain injury, and actually different psychiatric disorders I'll be talking about, and various cardiometabolic biomarkers. So my research, as Gary mentioned, started with the Navy, and I started out as a basic neuroscience researcher doing electrophysiology, doing microscopy, and I developed a wide range of various techniques that allowed us to understand extreme environments. So we have various environmental chambers in the lab, hyperbaric chambers to hypobaric chambers. So we could simulate the top of Mount Everest, or we could simulate the bottom of the ocean. And we simulate extreme environments, and the Department of Defense and the Office of Navy Research and DARPA sort of have funded us to develop the technologies to study cellular and molecular correlates of these extreme environments and sort of physiologically what happens in these environments. And Navy SEALs use a particular type of breathing apparatus called a closed circuit rebreather. And if they dive too deep, they can get seizures. So we actually study these seizures in rodent models, and it allows us to, we study it in cells, in tissues, and also in mice and rats. And it allows us to vet out and understand what types of therapies work best. And after a half a decade of studying different anti-seizure drugs and different pharmacological agents, I pivoted towards dietary therapies, specifically a ketogenic diet and exogenous ketones, when the drug therapies were not working, or I was seeing unacceptable side effects with including sedation, and animals would get lethargic. And when we would fast the animal for a period of time, that gave them tremendous resilience to seizures. If we put them on a ketogenic diet, that would also give them resilience to seizures in a high pressure oxygen environment. Oxygen is a stimulant, and if it gets too high, it can trigger seizure. And then we developed various forms of exogenous ketones, which the advantage there is that within 30 minutes, it would simulate the physiology of fasting for 1 week. And we can achieve therapeutic ketosis, and that was enough to mitigate the oxygen toxicity seizure. So we've basically moved the science into human application, working with NASA in space analog missions under the sea, and called NASA's Extreme Environment Mission Operations. And I was a scientific researcher on that and also a crew member. My wife was a researcher and also a crew member for mission number 23. And we've also moved the research in our lab into human clinical trials where subjects go inside a hyperbaric chamber, inside a pool, and they, basically they're doing cognitive tasks with a simulator, and we're taking blood that goes to a mass spec, and we're doing blood gases and metabolomics in real time. And we're basically assessing the metabolic resilience that is happening with therapeutic ketosis. So these studies were kind of like a springboard for many things that I'll be talking about in the different applications of therapeutic ketosis outside of this military research. But I got interested in this area of research after talking with many of the icons in the field. That includes, at the time, Dr. Richard Veitch, he was trained by Hans Krebs of the Krebs cycle. So he was an early mentor of mine. The late Dr. Richard Veitch, the late Dr. George Cahill, who's in the upper right-hand corner from Harvard, Dr. Theodore Van Italy, Dr. Sammy Hashem, all of those came from Harvard. They were trained at Harvard, and Dr. Henri Brunengraber from Case Western. So They were all icons in the field of metabolism, starvation ketosis, ketogenic diets, and exogenous ketones. And there was a study that was done in 1967 that really caught my attention because this study, it could not be replicated today because the IRB would not approve it. The ethics committee would not approve it. But they fasted subjects for 40 days. And these subjects were obese subjects, and then they looked at the AV difference of energy utilization in the brain. And they looked at glucose, beta hydroxybutyrate, which is a ketone, and then free fatty acids and acetoacetate. And essentially what they showed, what they demonstrated is that in a fed state, eating a normal diet at the time, the brain essentially derives 100% of its energy under normal conditions, a normal American diet, 100% of energy comes from glucose. But after fasting for over 10 days, roughly about 2/3 of brain energy metabolism is derived from ketone bodies, beta hydroxybutyrate and acetoacetate. So we liberate fatty acids for energy, but they can't readily cross the blood-brain barrier. So the liver converts these long-chain fatty acids into small, highly energetic molecules that are like water-soluble, like breakdown products of fat. And they enter circulation. The liver produces ketones, but the liver cannot use ketones as an energy source. But they spill into circulation, and the peripheral tissues use the ketones. In particular, the brain uses a vast majority of ketones, and also the heart. So I became interested in this idea of ketosis as a means to preserve and enhance brain energy metabolisms in specific contexts. For example, I was very interested in the potential for ketones to rescue the brain under hypoglycemic conditions. For example, insulin-induced hypoglycemia. An interesting extension of the study that George Cahill did in subjects that were fasted for 40 days. Towards the end of the 40 days of fasting, he injected the subjects with 20 IUs of insulin. So without giving them any kind of food. This pushed their glucose down into 1 millimolar, essentially. So in terms here, that would be 18 milligrams per deciliter. So I teach medical students that, anything under 3 millimolar of glucose is essentially critical hypoglycemia, and down to 2, you get significant CNS dysfunction, coma, and then seizure. What was interesting in the subjects that were basically pushed down to this level of hypoglycemia, they were completely asymptomatic for hypoglycemia. In 1967, the understanding was that the brain could only use glucose as an energy source. So this was a very brazen, very dramatic demonstration, and it changed the physiology books that the brain had the metabolic flexibility to adapt from using glucose to using ketone bodies as a source of energy. Now, Drenick actually pushed it even a little bit further, that he got blood glucose levels below 1 millimolar. The standard, off-the-shelf blood ketone monitoring systems, the finger prick devices, they won't even go below like 30. It just flashes low. So this was remarkable. This extreme hypoglycemia was mitigated because these subjects were producing ketones. And that really caught my attention and got me more interested in the idea of using exogenous ketones as a way to rescue the brain in the case of subjects that were not fasted, for example, type 1 diabetics that just injected too much insulin, or scenarios where there's impaired brain energy, brain glucose metabolism. And I'll discuss some of that. So we study a wide variety of different inborn errors of metabolism, and I won't cover them all, but they're associated with neurometabolic dysfunction, and that includes glucose transporter type 1 deficiency syndrome, pyruvate dehydrogenase deficiency syndrome, and a number of other disorders that have very long names. So we have the mouse models of these disorders, and then we therapeutically give them ketogenic therapies. So again, in this schematic, it just shows that with a ketogenic diet, therapeutic ketosis can be achieved with a ketogenic diet. The liver produces ketones, they get into circulation, and they readily cross the blood-brain barrier, and they also cross the cell membrane and the mitochondrial membrane. Under conditions of traumatic brain injury, under conditions of Alzheimer's disease, and other neuropathological conditions, there are a number of situations where you get impaired glucose utilization or glucose hypometabolism. So that could occur at the level of the glucose 1 transporter, the GLUT1 transporter. It could occur at the level of pyruvate dehydrogenase complex. It could occur at the level of the GLUT3 transporter on the surface of neurons. So in the context of, and I included this figure because we are now designing and getting ready to do experiments on traumatic brain injury using rodent models, but also human clinical trials. And a feature of brain injury, and this could also there's different forms of brain injury, and there's a lot of heterogeneity in the type of brain injury, how it occurs, what area of the brain, everything. But a universal feature is that right after brain injury, there's a high degree, there's glucose hypermetabolism. So the brain becomes very hot and very hypermetabolic for a short period of time. And after that, there's a protracted glucose hypometabolism. And that ultimately produces everything from headaches to post-traumatic epilepsy to psychiatric disorders, including depression. Migraines are very common, anxiety, and various psychiatric disorders. So we are developing various protocols that could be done to sort of assess traumatic brain injury and then do a metabolic intervention. So glucose hypometabolism is also a hallmark of Alzheimer's disease, and that's due to a number of different conditions. It could be brain blood flow, it could be pyruvate dehydrogenase deficiency, or the activity of that enzyme, which is more like the rate limiting enzyme for brain energy production from glucose. And also it has been observed using an FDG PET scan, and that's what's shown on the bottom images here. You have a normal brain and an Alzheimer's brain. And a universal feature or a hallmark characteristic of Alzheimer's, as I mentioned, is glucose hypometabolism. So this is also a feature in patients that have major depression. So this is universally recognized now, and it's becoming the glucose PET scans are being used more at our institute here, the Bird Institute. It's becoming kind of standard to do these types of scans. And so one way to induce therapeutic ketosis is with dietary therapies. In certain contexts, this could be it's difficult for some patients to induce and sustain therapeutic ketosis with a diet. Some patients are unwilling or unable to do that. So that sort of motivated us to, and also the time course is such that it takes quite a while to achieve and maintain therapeutic ketosis, and it's very hard to titrate it therapeutically. And many doctors are just not trained in nutrition, but we do know that there's tremendous anti-seizure and neuroprotective potential for these ketogenic diets. There's the classical ketogenic diet, which is upwards of 90% fat, the modified ketogenic diet or modified Atkins diet, and a diet called the medium chain triglyceride diet. So a medium chain triglyceride diet is more liberal in protein and can be more liberal in carbohydrates, but includes liberal amounts of ketogenic fats called medium chain triglycerides. And we use these types of fats quite often in our research and also in our clinical trials. What's different about medium chain triglycerides is that when you consume them, unlike long chain fats or various other saturated fats, is that they are transported to the liver via hepatic portal circulation. And unlike long chain fats, they're not packaged into chylomicrons. And The advantage to that is that when you consume MCTs, they rapidly go to the liver and they stimulate ketogenesis. So a lot of the MCT oil is actually converted into these ketone molecules that include beta hydroxybutyrate, acetoacetate, and acetone. So, and they all have very interesting biological effects. So you could circumvent the dietary restriction that's typically used to achieve and maintain ketosis with various exogenous ketones. So this could be ketone salts, simply beta hydroxybutyrate that's bound to sodium, potassium, calcium, or magnesium. So you can combine the ketone ionically with a monovalent or divalent cation. You can formulate it and they actually taste pretty good. So, and then there's ketone esters, which do not taste good at all, but they're significantly, they can be more potent, but most ketone esters commercially available are bound to 1,3-butanediol. And many formulations that are being sold commercially are just simply 1,3-butanediol, which is actually a dialcohol or an alcohol. And if you consume these types of ketone esters or 1,3-butanediol chronically, it is an alcohol and it will have negative consequences to the liver. So we know this, we just published a paper on it. It concerns us, and we are pivoting away from 1,3-butanediol based ketone esters and focusing more on the ketone salts and combining that with MCT. The advantage is that if you formulate it correctly, you can get the potency of a ketone ester with essentially no toxicity. And that has been a focus of what we're doing now. So exogenous ketones can elevate the ketone levels in your blood to a level that's similar to a strict ketogenic diet. So we know that these ketone bodies can replace or largely replace glucose as an energy source in the brain. So they have remarkable ability to function as an alternative energy. But a big thrust of our lab is actually studying the neuroprotective signaling mechanisms of these molecules. So we look at their effects on different reactive oxygen species, on the neuropharmacology of the brain changes significantly when you induce and sustain ketosis. It elevates GABA levels, reduces glutamate, it suppresses inflammation. And my student that just graduated, my PhD student, she just focused on looking at the epigenetic effects of ketones. So ketones can actually stimulate various gene programs that confer protection in the body. And we have various technologies where we can, like the Keto Mojo device, which we can prick our finger and measure glucose and ketones and get the glucose ketone index. And that's a really important biomarker for tracking ketones. And I'm also wearing a continuous ketone monitor. So in the upper right-hand corner is an example of consuming 15 grams of beta hydroxybutyrate salt, keto start, which actually tastes good, unlike the ketone esters, and you can induce and sustain ketosis for hours. And we use various formulations of these ketones in our research, and it's not like you could do the ketogenic diet or exogenous ketones. What we often like to do is do a therapeutic carbohydrate restriction, but it does not have like 90% fat. It may be 50, 60% fat and more protein, but it's not ketogenic enough. The fat content is not high enough to induce and sustain therapeutic ketosis. So we just simply add a shake to the meals to push ketosis to a level that is similar to a very strict ketogenic diet. So we're doing that for various studies, including with the Moffitt Cancer Center. And what the Moffitt Cancer Center is interested in is that the ability of ketone metabolic therapy to augment and enhance immune-based therapies, including checkpoint inhibitors and CAR T therapy. So that's the big focus because there's a lot of preclinical animal model data and some clinical trial data to suggest it can make these cancer therapies work significantly better. So that's a big focus of what we're doing now. And I would say, 10 years ago, there was about maybe like 10 registered clinical trials on clinicaltrials.gov. And now we have nearly 500 registered clinical trials on clinicaltrials.gov, which is database website for this. And it involves many different applications. Obviously, epilepsy and seizures, that is like the kind of the main, that has historically since 1921 been sort of the therapeutic use of a ketogenic diet. That's why it was developed. But in parentheses here are the number of clinical trials. So Alzheimer's disease, Parkinson's disease, cancer, muscle wasting, weight loss, type 2 diabetes. So these are on the right or the left-hand column are evidence-based applications in many, different genetic disorders or inborn errors of metabolism that we study, seizure disorders. So there's also an emerging area of research, evidence-based research that I think will be ultimately accepted. So an area that has been rapidly emerging is psychiatric disorders. So that includes bipolar, major depression, anxiety, and even things like anorexia nervosa. So anorexia nervosa is a psychiatric disorder that kills more people than any psychiatric disorder. So that there's data and research showing that ketogenic therapies can be therapeutic for that. So I won't go through all these different emerging applications, but you get the gist that this is a very rapidly growing field of research. So years ago, my wife, Chilla, she was trained as a neuroscientist in Budapest, Hungary. And when she came here, she was very interested in the behavioral effects of exogenous ketones and ketone metabolic therapy. And she published there's a number of publications that she did, including showing the anxiolytic or anxiety reducing effects of therapeutic ketosis. And we did this in a number of different animal models, including Sprague Dawley rats and the albino, we call it the WAG-GRI model, that we have our investigators in Budapest, Hungary use that model for their seizure studies. And we published a review of the current literature on therapeutic ketosis for treatment of psychiatric disorders. And I believe that was kind of like a springboard for other people to get interested in it. And now on clinicaltrials.gov, there's many different clinical trials, everything from bipolar disorder to, as I mentioned, schizophrenia, major depression. There's research coming out every week. And that has been amazing to see this area of research really expanding. And that's largely there's some NIH funding for that, but the Bazuki Brain Research Foundation, or the Bazuki Group, is funding a lot of, and that includes Jan and David Bazuki. Their son had bipolar disorder, and they're philanthropists that are funding a lot of research at Harvard, at Yale, at OSU, at University of South Florida. So it's a very interesting and rapidly emerging area of research using metabolic-based therapies for these psychiatric disorders. So it had spawned a new area of research called metabolic psychiatry. We have, for the last maybe 16, 17 years, we've been studying the effects of therapeutic ketosis on brain cancer and metastatic cancer. And this application was brought to my attention by Dr. Thomas Seyfried. So Dr. Seyfried and I connected about 16 years ago, and we use his model of metastatic cancer. And on the bottom here, I included the PMID numbers because I can't show all the different studies we did. But if you just simply look at the PMID number and Google that, that'll bring you to the publication. But essentially what we showed is that ketogenic diets and hyperbaric oxygen in combination were very synergistic and therapeutic for suppressing cancer growth and improving the survival of mice with metastatic cancer. So on the left here, liver metastasis was really what would kill a lot of our animals. So the liver is a very fertile organ for cancer to grow, and we would implant the tumors into the flank of the tumor cells into the flank of the animal. And the particular model that Dr. Seyfried developed at Boston College, which we acquired and used at University of South Florida, the cancer cells would rapidly get into circulation and spread to the brain, to the organs, and to the liver. So it became a very effective model to assess different metabolic-based therapies. And I feel we're just at the cusp of understanding how we can leverage and improve the dosage and the timing of the therapeutic ketosis. And we're also looking at many different metabolic drugs, including everything from metformin to drugs that target glutamate to drugs that target the glycolytic pathways. And I've had a number of PhD students in my lab and train, with this model, including Dr. Angela Poff, Dr. Nate Ward. He has a lab at Moffitt Cancer Center now, and he's mostly interested in the drugs. And Dr. Andrew Kutnick, he studies cancer cachexia. And we've had a number, it's just some of the students in the lab. So this is a very uh, fertile ground and fruitful area of research. And I think we are at the cusp of moving these types of therapies into clinical trials and ultimately into standard of care. And, when I started this research, maybe there was 2 studies on clinicaltrials.gov. And in 2025 now, we have 47 studies you can find on ketogenic diet and cancer. And that includes types of cancers: glioblastoma, pediatric brain cancer, glioma, brain metastasis, breast cancer, prostate, pancreatic, head and neck cancer, endometrial, renal cell carcinoma, lymphoma, and advanced metastatic cancer. So just some of and there's 10 studies specifically for ketogenic diet and brain cancer. And I know most of the principal investigators behind those studies. So, and I'm, keeping track of the research that's going on. So in our lab, we mostly do preclinical animal model work, but I work with the clinics to help them design the types of ketogenic diets, including the Moffitt Cancer Center. So this was Seminars in Biology Review that we published with the lead investigators at Moffitt Cancer Center, including Dr. Nagy Kumar, the neuro-oncologist there, Solomaz, and Dr. Kathleen Egan. She's the chief epidemiologist there. And we published this article in this journal entitled "Targeting the Warburg Effect for Cancer Treatment." So cancer cells are metabolically altered in a way that their metabolism is compromised that prevents them from using ketone bodies as an efficient source of energy. So they rely almost exclusively off glucose, and then they can also use glutamine. Ketosis can basically target all the hallmarks of cancer. So there's a seminal paper called The Hallmarks of Cancer, and many different drug therapies are developed to target, 1 or 2 hallmarks of cancer, but ketogenic therapies basically target all the hallmarks of cancer kind of synergistically. They just do it in a more nuanced and gentle way instead of, some of the drugs that are out there that cause major side effects. So only after about, 6 or 7 years of, kind of talking to the Moffitt did they sort of realize that this is something that they want to be using in the clinic. So we are working with them on a number of different clinical trials now, mostly to enhance the standard of care. So using these ketogenic therapies as an adjuvant. The implementation is really the key. So therapeutic ketosis strategies for the metabolic management of cancer can differ. So there are strategies that include, if the patients are overweight, you can get them doing prolonged fasting, but this is really not suggested because it's really not sustainable, but people have written about it. Of course, if you extend the fast too long, that essentially becomes starvation. And if the patient has cancer cachexia or muscle wasting, that is not something you want to continue doing. So it really needs to be personalized and adjusted to each patient. So our lab really focuses on precision ketogenic diets, and in some cases, a calorie-restricted ketogenic diet and ketone, various forms of exogenous ketones. So we use that umbrella term, ketone metabolic therapy. So Dr. Seyfried and colleagues, as I was just getting into this space, they published a case report with a glioblastoma patient that achieved and maintained management of a glioblastoma. And to do that, you have to implement very strictly a restricted ketogenic diet to lower blood glucose and elevate ketone levels to achieve what is termed the essentially a glucose ketone index of 1 or 2. And if you can achieve that and maintain that, that has a significant effect at reducing cancer growth And it makes the cancer much more vulnerable to other modalities that you can target the cancer with. So that could be standard of care like chemo and radiation or immune-based therapies. But our lab is very interested in non-toxic metabolic management of cancer, and that could include oxidative stress therapies like hyperbaric oxygen. It could include intravenous vitamin C. And we have a whole toolbox of different metabolic drugs that we're testing now that could synergize with the ketogenic diet. We did publish a review, and there's 49 authors on this review that include neuro-oncologist Dr. Thomas Seyfried he's at the bottom here, makes him the senior author, and Dr. Tomas Durai is the first author of this, and it was really a team effort to put together, the original manuscript was like 200 and some pages, and we got it published in the British Medical Journal, but it's the clinical research framework proposal for ketogenic metabolic therapy for glioblastoma. And I think that a clinical research framework can be developed for breast cancer, for lung cancer, and it's going to look similar, but there's going to be each review is going to be quite different because there are differences between different types of cancers, and that needs to be appreciated. And therapies need to be developed specifically for different kinds of cancer. Glioblastoma is the most aggressive cancer that we know of, so it made sense to start with this. Also, the standard care therapies simply do not work to improve patient overall survival. They may add a few months, but I would encourage people. This is a very big review. It's got many figures and hundreds of references to just Google the name of this if they're interested in this area of research. But a key thing in this particular review or this idea is achieving and maintaining a glucose ketone index of Thomas Seyfried believes at 2 equal to 2 or under 2. But I think if you can get a glucose ketone index between 1 and 4 and maintain that, that's going to be remarkably effective at the very least, slowing the cancer growth and making cancer a more vulnerable target to other modalities. And this particular review goes deep into that. And we have, I think, 6 supplementary files that are at the end of this that there's direct links to, and it's 100% open access. So it's free, and it's basically probably the most comprehensive review that has ever been written about ketogenic diets and ketone metabolic therapies for cancer. And I think it definitely applies to more than just glioblastoma. So I direct people's attention to that, and it gives you a step-by-step way to implement this metabolic therapy and how to synergize it with other therapies. And there's also a library of various repurposed drugs that could also be used with the dosages and also the references on that. But I can't talk about more because there's just so much to talk about with that paper, but we're really excited that we got that. It took about 2 years to get that published. So I want to pivot a little bit to biomarker self-monitoring because achieving and maintaining ketosis is really important to get the therapeutic effects. And there's various technologies out there like the Precision Extrameter, the Keto Mojo device. These are devices that you can get on Amazon. I'm using a continuous ketone monitor. In this particular trace here, this is a 24-hour trace consuming an exogenous ketone, and you can see that ketone levels are quickly go up to the 2 to almost 3 millimolar range and is sustained for hours after a single dose. And so obviously, like to achieve that and sustain that over a period of time, you'd have to take about 3 doses over the course of a day. And anything above that blue line there is considered clinically therapeutic ketosis. So these levels were actually very high. You don't need to achieve that. I was testing a different exogenous ketone. So one thing I want to draw people's attention to is that with the use of a continuous glucose monitor, this is an example of a patient that had type 1 diabetes, and it's 7 days of continuous glucose monitoring with the standard American diabetes nutrition or meal plan, right? So you could see wild fluctuations in glucose and a high degree of glucose variability. When the patient was switched and maintained to therapeutic carbohydrate restriction, so this is the bottom panel is 1 week of glucose traces after therapeutic carbohydrate restriction. So there's no drug in existence that even comes close to achieving and maintaining a safe and level of glycemia that therapeutic carbohydrate restriction can achieve. So, and this would be difficult to quantify without the use of a continuous glucose monitor. I think so. These devices are really helpful for us in research to sort of validate the efficacy of these of different dietary therapies. Also, when patients are wearing a continuous glucose monitor and the data is going into an online platform, it gives the investigator a window to understand if that patient is cheating or getting off their diet. So that becomes really important. I would also like to bring people's attention to the bottom right-hand panel. I was in various experiments that I like to do, I like to test various keto products that are in the supermarket. And there was a keto cereal that was the most popular keto cereal that people were talking about. And I'm not going to mention the name of the cereal, but I purchased the cereal and consumed it, and it gave me a pretty large elevation, a pretty large spike in glucose. So you could see the elevation going from roughly 60 or 70 or 80 milligrams per deciliter and shooting past upwards to about 140 milligrams per deciliter of glucose levels. And you can also see that there was a pretty sharp decline in glucose and a postprandial dip in glucose. What that information told me that my body was releasing insulin in response to this keto cereal that was being sold and marketed as a ketogenic diet cereal. So I think, these continuous glucose devices are really important for understanding your personal response to individual types of foods and the amount of foods, and then you can titrate and adjust your meal plan to achieve and maintain, your glucose within a particular parameters. And I think that's really important. So other biomarkers that you want to be aware of when you're doing ketone metabolic therapy is your level of insulin, and there are various kits out there. We've used, ZRT labs, and there's various kits that they'll send to your home that you can do, or you can just get the test. But insulin is really not a standard test on a comprehensive metabolic panel. It should be. And there's various reasons that it's not that I don't agree with, but insulin should be measured. Insulin resistance is really the hallmark characteristic of metabolic dysregulation. And the levels of insulin that we try to achieve and maintain in patients for optimal metabolic health is between 2 and 6. And then HSCRP is also a really important cardiometabolic biomarker. It's even in the literature, it's far more predictive of atherogenic risk than LDL cholesterol. We have in medicine, and even, in our medical education, we have a myopic focus on LDL cholesterol and almost a manic focus on that because we have drugs to lower it, right? But HSCRP is probably a more important biomarker to look at, and you want to make sure if you can to achieve, below 1 milligram per deciliter. 20 years ago, I've been monitoring that for quite some time. And when I was on a higher carb diet, mine was fairly high. And on a ketogenic diet, it's come down quite a bit. So hemoglobin A1C, triglycerides, ApoB, and B12 are all things that I think are really important biomarkers or things that should be added to your blood panel. And interestingly, with ApoB, is that low ApoB and low LDL actually correlates with a higher risk of cancer. So we don't understand why that happens, but there could be reverse causality. And I've had many conversations with David Diamond about this, and he has different theories. But this is a publication that discusses sort of, this low ApoB and LDL cholesterol is associated with a greater risk in cancer. I have observed in cancer patients that as their cancer becomes more metastatic and they have a higher tumor burden, that the LDL levels will come down, and that's not a good thing to see. So I've also observed, many individuals in very, very robust health in advanced age with very high LDL and very high ApoB, and they don't have any cardiovascular risk or any plaques. So that's a sort of an emerging area of ketogenic therapies because many doctors, when they see an elevation of ApoB and LDL, they have a knee-jerk reaction and automatically, prescribe a statin drug. So there's various advanced testing that we use sometimes in our research, and I've used personally. Genova Diagnostics has different tests, and I've used a number of different companies. But I think it's important that diet preference and other factors need to be considered when interpreting the results of these tests. For example, when I did the Genova test, it was telling me that my, beta hydroxybutyric acid was out of normal range, and that was a problem. So it was in the red zone. But that's a good thing because, I am practicing, therapeutic carbohydrate restriction and ketogenic diet. So they also have an omega-3 fatty acid test, I think is really, really helpful. And I eat a lot of fish and at least like probably 3 to 4 servings per day. So I thought it was prudent for me to measure my heavy metals. And after eating a large amount of fish, on a vacation in the Dominican Republic, and I didn't know where those fish were coming from. When I got back, I did a heavy metal test, and my mercury was like almost non-detectable, and my lead was low. So I thought that was a good indication that the fish that I'm eating is not high in heavy metals, and I tend to gravitate towards smaller fish that have a lower heavy metals just in general. But I did, when I got back from vacation and I did this test, my bismuth levels was off the charts. And I'm only showing 3 things here. I think it measured maybe like 20 or 30 different elements. And the bismuth was elevated because I had taken Pepto-Bismol, which apparently has bismuth in it. And that's so that's for like I ate something during my travels that triggered sort of gastroenteritis. So I took some Pepto-Bismol. It was pretty mild, but the Pepto-Bismol that I had several days earlier was flagged and caught on this test. So that's how sensitive these tests are for picking that up. And apparently that's not toxic, but it was just something that, you want to be aware of. And the omega-3 index test, Rhonda Patrick connected me with the company that makes that, and I've been doing the omega-3 index test. And I do not think it's necessary to take an omega-3 supplement if you're eating fish. So that was I get about four servings of fish per day, and my omega-3 index was maxed out to be in the optimal range. So I do want to mention that there are some side effects associated with a clinical ketogenic diet that we talk about in the clinic. Contraindications could include pancreatitis, liver disease, and fatty acid oxidation disorders. There's carnitine deficiency that could be primary or secondary. Potential for electrolyte deficiency. So I'm a big proponent of electrolyte supplementation, liberally salting your food. Ideally, too, you could take a ketone salt supplement. So that is basically ketones bound to sodium, potassium, calcium, magnesium. So you can get those because the ketogenic diet has a diuretic effect and a natriuretic effect, especially the first 2 or 3 weeks. So we often see some of these electrolytes tend to get low, and people will get some side effects from that, orthostatic hypotension and things like that. So lipid abnormalities can occur in some people. The thing that I get concerned about is elevated triglycerides on people on a ketogenic diet. It's rare, but it's an indication that they're not metabolizing fats efficiently. So they need to reduce the amount of fat, maybe add more protein, and then let their body adjust to the high fat intake. There's sort of in the literature, there's a risk of kidney stones, but I think that could be mitigated simply by hydration. A lot of people ask me if they had their gallbladder removed, can they tolerate a ketogenic diet? I have found a number of people can do therapeutic carbohydrate restriction with a higher protein diet and be totally fine. And over time, the pancreas can make the lipase enzyme, and it can make it enough to basically not have any side effects with a ketogenic diet. So there's some discussion about females getting a potential for amenorrhea or reduced thyroid. So I've put the PMID numbers in there, and I don't think there's anything to be concerned about too much as long as protein is sufficient. And there is reported, it's very clear in the literature that there's a reduction in T3 thyroid in women that are on fairly restrictive ketogenic diets, but they were not symptomatic for low thyroid. So their thyroid, their T3 was low, but it appears maybe that they were more sensitive to the active T3, and they did not present as having any symptoms of low thyroid. So this is an ongoing area of research, and I'm connected with some of the investigators looking into that. So that's sort of the gist of the presentation. And here are just some of the current research that I kind of summarized. I would like to kind of mention that. So I'd like to mention too that I don't use statin drugs, but at one point I had pretty high cholesterol in the 3 to 400 range, and I got a xanthelasma, which is cholesterol deposits at the top of my eye. And I got a little bit concerned about that. And I did a genetic test, which indicated I had a genetic mutation in the MPC1L1 receptor. So I hyperabsorb cholesterol, and there's a drug sold as Zetia or ezetimibe. So ezetimibe monotherapy essentially just works at the level of the gut to prevent excess cholesterol absorption. And this particular drug that I take a half a dose every day, a couple of times per week, and it has cut my ApoB levels in half, and I no longer get xanthelasmas, and it also lowered my triglycerides too, and elevated my HDL cholesterol. So that is something that I found just through experimentation and testing. I did GB Health Watch, which is a genetic test for this particular uh, genetic disorder, if you want to call it that, for hyperabsorption. So this is an area that I'm pretty interested in, and I'm connected with some investigators that are looking into people that are lean mass hyperresponders, meaning that have elevated sort of LDL, but they have low triglycerides, and they're experimenting with ezetimibe and that, which is not a statin, but it sort of works at the level of cholesterol absorption. And some of the areas that we're focusing on now are neuroprotection, and then moving various ketone metabolic therapy into clinical trials for brain cancer and neurometabolic diseases. So that's an area of active investigation now. And yeah, so with that, I'd like to thank you for your attention. I can't do this work without the help of my wife. She's really sort of in the trenches doing a lot of the work, in the lab. And we have a great group of PhD students, medical students, postdoctoral fellows, and collaborators that really help us with this work. And I've just highlighted some of the key publications that were kind of referenced throughout the talk. And if anyone wants a copy of my presentation, I'd be glad to send them the PowerPoint or PDF file too. So with that, I want to thank you for your attention. If you have any questions, I'm free to answer them.
Dom, I think.
Yeah.
Sorry,
go ahead.
Your presentation, you say, you go.
Oh, yeah. So I'm finished with the presentation, but I just had a couple extra slides. If people have questions about ketone supplementation, sometimes they have, and then just highlighting some of the books that I've sort of, been involved with, and books that I think are really excellent resources, especially in regards to cancer, the work of Dr. Thomas Seyfried, who's been a really good friend and collaborator of mine, and the various publications. I think, if people want to take a deeper dive into this, into the science and the application of ketone metabolic therapies.